Good afternoon, dear colleagues. It is a great honor for me to participate in these already traditional, extremely significant, highly informative, and exceptionally meaningful conferences, which have now become a tradition. I would like to express my sincere gratitude and profound appreciation to the dedicated organizers and visionary initiators of these important conferences, and in particular, this significant and timely conference that is taking place here today. And in today's important presentation, in this comprehensive speech, I would very much like to focus intently on the significant and complex issue of extracorporeal blood hyperthermia. And in fact, I aim to delve deeply into its various aspects and implications in the treatment of such a condition as exudative pleuritis. In general, if I may, Professor, the next slide, please. In general, regarding the heating of blood or the heating of the human body as such for therapeutic purposes. Thank you. This is an extremely ancient, extremely, so to speak, a very old method. And since ancient times, people have consistently warmed themselves by the comforting glow of the fire to significantly boost the inherent immune properties of their bodies. And throughout history, on the English fleet, we know that heated alcoholic beverages were consumed depending on one's rank in the Navy, whether it was grog or wine or something similar. And we also know that the ancient practice of soaking one's feet in comfortably hot water, along with various other traditional methods, were commonly employed to effectively warm up the body. For instance, the simple yet effective act of drinking a steaming cup of hot tea was a popular and comforting way to achieve warmth. Throughout history, people have consistently and keenly observed that an elevated temperature promotes healing and contributes to overall health. Today, we can confidently and unequivocally state with absolute certainty that it's not merely warming the entire human body, but rather it is specifically and directly heating the vital blood itself. This profound physiological effect also inherently possesses a significantly positive and beneficial therapeutic impact. And this is no longer, let's say, just purely theoretical or merely experimental work. We are indeed talking about this at the significant level of currently existing treatment protocols, and specifically at the official level of formally approved treatment protocols within the United States of America. In America, a reputable organization, for example, such as the well-known blood bank, the AABB, which stands for the American Association of Blood Banks, the American Association of Bank of Blood, and various others, including the esteemed Canadian Association and the New Zealand Association. In other words, these are already well-established and recognized entities. Procedures for heating blood. They are included in treatment protocols and resuscitation treatment protocols with the exact temperature to which the blood is heated clearly specified, namely up to 38 degrees. And there are already quite a lot of publications that confirm the actual therapeutic positive effect. I would like to focus based on the current established military medical protocol, specifically the comprehensive TCCC standards and also the TIV standards. And it is also very clearly stated within these guidelines that for wounded soldiers on the battlefield with significant blood loss, active blood warming is absolutely indicated. This involves the hardware warming of the blood itself to a precise temperature of 38 degrees, and also the crucial warming of the wounded individual. So according to the standards, according to the Marsh standards, when wrapping the wounded, it is mandatory. Heating, warming, according to the last letter H, it is included. So in this particular case, according to the established standards and the comprehensive NATO TCCC protocols, it is absolutely mandatory to strongly recommend the immediate warming and careful administering of appropriately warmed blood to the severely wounded, especially in critical cases of significant blood loss. A rather large study was presented, a multi-center study, I would even say. It concerned the protracted and devastating wars in Afghanistan and Iraq, where dedicated American military medics diligently studied the alarming and pervasive warming trends, meticulously observing their profound effects of blood that is transfused to the wounded. And regarding this, it was confirmed that administering within the first hour in cases of severe blood loss, transfusing warmed blood significantly increases the survival rate of the wounded. And it is noted that there is a clearly pronounced truly therapeutic effect. And most importantly, the survival rate increases by more than 2 times. The survival rate of patients, if wounded with severe blood loss, increases when warmed blood is transfused within the first hour. Next, Professor, I would be grateful if you could show the next slide. According to the established guidelines and clinical protocols in American, North American, Australian, Canadian, and North African medical standards, the current and widely accepted clinical indications for the appropriate and safe transfusion of pre-warmed blood products are comprehensively outlined as follows. First of all, this is massive blood loss. If there is a need to transfuse a large amount of blood during resuscitation, then accordingly, in cases of significant blood loss, it is preferable and recommended by standards to transfuse warmed blood. Next are exchange blood transfusions in newborns, as well as traumatic situations where general body warming measures are needed. I would also like to focus on this point as it somewhat aligns with NATO TCCC standards. If there is a need, dear colleagues, all those resources will be made available. References to which standards and links to these standards, as well as to unified treatment protocols, will be provided. Additionally, blood warming is specifically indicated as a crucial phase of comprehensive patient warming during complex surgical procedures that extensively involve cardiopulmonary bypass, ensuring optimal thermal management throughout the entire operation. Next, please. Dear Professor, after carefully considering previously mentioned, we proposed a method to carefully and gradually warm the patient's blood with the vital blood continuously circulating within a precisely controlled and completely closed circuit system, ensuring optimal therapeutic conditions. I will go into more detail later, but the principle is as follows. Blood is drawn from one cubital vein. The patient's blood is collected, sent to a blood warmer, and heated to a temperature of 38 degrees Celsius. And this same blood, in a closed cycle, I repeat, is supplied to the second cubital vein. The principle of blood heating is as follows. When pouring, the release of interleukins is observed in the blood and is characteristic. The initial mechanism is the release of interleukin 1, which is one of the active pro-inflammatory cytokines. This, let's say, initiator, interleukin 1 subsequently produces a cascade of reactions, a cascade of the release of interleukin 3, interleukin 4, 5, 6, 8, and gamma interferon. And it triggers chemotaxis of macrophages and neutrophils, promoting their migration through the vascular endothelium. At the site of inflammation, it activates the synthesis of cytokines, prostaglandins, collagen, and acute phase proteins, including C-reactive protein at the site of inflammation. I would be grateful, Professor, for the next slide. Interleukin 1 is also a factor in the activation of growth and maturation. T and B lymphocytes, NK cells, fibroblasts, and endothelial cells. It increases antibody secretion by B lymphocytes, stimulates hematopoiesis, exhibits radioprotective effects, and in some forms of cancer has anti-tumor activity. Although we remember that, in fact, interleukin-1, as was shown on the previous slide, stimulates, among other things, the subsequent secretion of gamma interferon, which is a direct anti-tumor factor. Interleukin-1 stimulates the synthesis of hormones in the hypothalamus, pituitary gland, and thymus. Next slide, please, Professor. I would appreciate it. Thus, we have successfully proposed and officially patented an innovative device for effective blood irradiation. I would like to emphasize that today there are not just many, but a great many devices for blood heating. There are really a lot of them. Basically, there are two primary main types. There are essentially two primary systems for effectively heating this blood. One system is where the actual tubing is carefully wound over the heating device itself, and another distinct system is where it is gently inserted inside the blood bag. And the blood bag is then placed into a sort of book-like device that efficiently heats the blood from the outside surfaces. In the vial, in the bag. An operational extracorporeal blood hyperthermia device consists of the following key components. These include an automatic thermostat, a cylindrical heating device with spiral-shaped grooves, where a polyvinyl chloride tube is placed. Inside this tube, blood from the patient flows and is heated to the specified temperature. There are heating and temperature sensors, and the device is covered on top with an external heat-resistant cylinder. And the blood is continuously supplied to the specialized heating device utilizing a rotary pump, and then the system of pipelines. Today, we are already actively developing and meticulously finalizing a sophisticated device in which there would not be a separate, distinct heating unit, a separate dedicated roller pump, and accordingly, a separate individual bottle containing essential anticoagulants. Instead, all of these crucial components are thoughtfully contained within one remarkably compact and integrated device. Next, please, dear Professor, the slide. How exactly does the procedure of extracorporeal blood hyperthermia take place? The patient lies on the operating table with the right and left arms resting on flat armrests. Before the procedure, for anticoagulant purposes, the patient is given heparin intravenously at a dose of 200 units per kilogram of body weight. As we have already mentioned, dear colleagues, blood is drawn from the central vein using an initial catheter and in close proximity to this catheter to the patient's bloodline. A heparin solution is administered through a three-way stopcock into the line at a dosage of 50 to 75 units per minute from the vial. Next slide. The line with the patient's heparinized blood passes through the roller pump. Next, it is delivered to a cylindrical heating device with spiral grooves. Then, the required temperature is already set in these grooves. Professor, I would appreciate the next slide. And then the heated blood through the system and the lines is delivered into the other opposite major vein of the patient. If the blood is drawn from the right arm, then the heated blood is delivered to the left arm. The procedure is performed for 30 to approximately 45 minutes, up to a full 60 minutes, depending on the specific nosological forms. The temperature on the heating cylindrical device is carefully set between 38 and 39.5 degrees Celsius, but according to the established protocols in the officially approved treatment protocols, the precise official blood heating temperature is clearly and unequivocally 38 degrees Celsius. We strictly adhere to this temperature of 38 degrees so that, so to speak, we do not deviate from the protocol indicators for blood heating. I would like to say just a few additional words regarding the actual process of blood heating, specifically focusing on the method of extracorporeal blood hyperthermia. A significant question arises here, doesn't it? Yes, it is truly very good, very effective, and it's important to note, let's say, does not have any unsubstantiated release of potentially harmful substances. This is because if we are talking about hypothermia at significantly low temperatures, there are theoretical studies which suggest that at low temperatures, when blood is cooled, bradykinin is released, which can have certain physiological effects. Accordingly, no negative effects on the human body have been observed at high temperatures. Secretion is typical, well, at around 38 degrees. There has been absolutely no conclusive evidence of the significant release of any harmful substances or detrimental proteins at this specific temperature. Indeed, heat shock proteins are definitively not released at all, or not in such quantities that would significantly contribute to the development of any complications. And I would like to particularly emphasize that there are quite a significant number of studies. To date, there are many comprehensive studies regarding the heating of blood. And I repeat once again, this crucial heating research is being actively conducted in leading countries. In many developed industrial countries, it is widely considered a leading and highly effective therapeutic method. Next, dear Professor, I would particularly like to emphasize this point, dear sir, as it holds significant importance. Professor Valentin Shapovalov is a co-author of this article, and regarding this method, a publication has already been prepared together with the esteemed professor. Valentin Shapovalov, in fact, has meticulously developed all the intricate legal aspects, and in this particular and significant case, the precise application of extracorporeal blood hyperthermia, which is an extremely important and crucial medical procedure. However, it is essential to note that these methods are remarkably universal in their scope and applicability. He has truly accomplished an enormous and substantial amount of work in this field. For example, informational materials, orders, and everything is clearly laid out step by step. What needs to be done, how to do it when applying this method in an official medical context. To date, 5 patents have been obtained regarding the treatment with extracorporeal blood hyperthermia. This is a method of treating extracorporeal blood hyperthermia for the treatment of exudative pleuritis of non-specific origin, a method for treating empyema pleura with the use of extracorporeal blood hyperthermia. MPM in the pleura can be considered as a subtype of exudative pleuritis or as purulent exudative pleuritis. The next method is a comprehensive treatment for lung oncopathology complicated by inflammatory processes. The method of extracorporeal blood hyperthermia. In the treatment of exudative pleuritis of tuberculous origin, a patented device for extracorporeal blood hyperthermia is used. Dear Professor, I would be grateful if you could show the next slide. These 5 significant and important patents are clearly presented on this particular slide, dear esteemed colleagues, and in this comprehensive presentation, we would very much like to thank you for your attention. To thoroughly report on the detailed and comprehensive results of utilizing extracorporeal blood hyperthermia in the treatment of exudative pleuritis, a condition requiring careful consideration. I would appreciate the next slide. The study involved 50 patients who underwent extracorporeal blood hyperthermia as part of their comprehensive treatment, 24 patients with pleural empyema and 26 patients. And with exudative pleuritis of non-specific origin. Next slide, please, dear colleagues. 26 patients with exudative pleuritis received extracorporeal blood hyperthermia as part of their comprehensive treatment. The control group consisted of 15 individuals with exudative pleuritis. They did not receive extracorporeal blood hyperthermia. The patients complained of shortness of breath and weakness. In 6 patients, the exudative pleuritis was total, accompanied by severe shortness of breath and signs of respiratory failure. An increase in body temperature in patients was observed from subfebrile levels up to 38.5 degrees Celsius. Of course, we are talking about exudative pleuritis here, not empyema. With empyema, pleuritic fever is usually observed. In addition to this, significant high body temperature readings are also typically noted in patients with this condition. Next slide, please, dear professor. Laboratory examination confirmed the presence of leukocytosis in the patients. In the first and control groups, respectively, it was 10.5 plus or minus 2.3 and 10.3 plus or minus 2.9. From this leukocyte formula, a left shift was also observed and the nitroblue tetrazolium reduction test was performed, which indicates the functional activity of leukocytes. In patients of the first and control groups, the nitroblue tetrazolium reduction test was decreased accordingly. 4.2 plus or minus 0.71 and 3.98 plus or minus 0.67, with the normal range being 7 to 9%. I would appreciate the next slide. In patients of the first group, after undergoing comprehensive treatment with the use of extracorporeal blood hyperthermia, thank you. On the 7th day, there was a significant subjective improvement in the overall condition. The intensity of retention decreased significantly, body temperature normalized, and the feeling of general weakness disappeared. In the control group patients, subjectively, no improvement in overall condition was observed on the 7th day. The intensity of retention decreased only slightly, and the increase in body temperature also decreased only slightly. Next slide, please. The level of blood leukocytosis in patients of the first group significantly decreased to normal values. 62.7% in patients of the control group, practically unchanged. 94.8%. A significant increase in the nitroblue tetrazolium test was observed in patients of the first group, while changes in the nitroblue tetrazolium test in the control group were not significant. The average hospital stay for patients in the first group was 18.4 days, and for patients of the control group, practically... No, next slide, please. Next slide, please. Can we go to the next slide? Thus, dear esteemed colleagues, it can be definitively stated that the comprehensive and innovative use of the method of extracorporeal blood hyperthermia in patients presenting with exudative pleurisy has demonstrated an absolutely significant and profoundly positive therapeutic effect, which is clearly evidenced by a remarkable reduction in the overall duration of the treatment course, leading to improved patient outcomes and a decrease in leukocytosis. And the overall effectiveness of the treatment itself is much, much greater. More positive. The clinical effect in patients who underwent extracorporeal blood hyperthermia further confirms that the method is effective. And that's it. It is well tolerated by patients with no serious side effects or complications. And we recommend this method, including in this particular case, specifically regarding this presentation, for use in patients with exudative pleuritis. Thank you for your attention, dear colleagues. I wish you all the best. Good health and all the best to all the participants of the conference.